Welcome everyone to this evening fifth series of GI surgery virtual rounds. And today with me is my co-moderator is Mr. Najmi, who is a consultant upper GI surgeon from KPJ Hospital Penang. Right? And today we are going to have our speakers, Dr. Sekkapan, uh, who is his second time presenting today, and he's going to bring us to his experience and cases that he's been through in the hospital, UKM. And, Dr. Sekkapan has been a general surgeon since he graduated from UKM in 2016. And he's have in early years of his general surgery, he worked in the Hospital Sultanah uh, Aminah Johor Bahru as a general surgeon, and now he's pursue his a subspecialty program in upper GI surgery. And before I forget, then we're going to have some housekeeping announcements. You'll be muted. Your audio will be muted throughout the whole webinar. And if you have any questions, please type it in the QA sessions, and it will be recorded for internal purpose. And e-certificate will be sent to you at the end of the webinar, and this certificate will prove attendance for you to claim CME points via NSR or MMA. And there will be a survey link sent to you after the webinar, and hope you can answer them and send back to us so that we can improve further in our future series. And if you have any further questions regarding to the products that been by our sponsors today, which is the LabTech. LabTech going to share with some video later, and you may actually mention in your survey forms, and we get back to you any information required for our sponsors for today, which is LabTech. And Dr. Sekkapan today is going to share with us about his second topics about a DJ Flexure tumor in an emergency setting. And without further delay, I will pass the page to Dr. Sekkapan, and he will share with us his experience. Dr. Sekkapan, please.
Thank you very much, Mr. Lim, for the kind introduction. And good evening to everyone. So this is my second topic. So I'll be talking about a duodenojejunal junction tumor and emergency dilemma. So this one particular case which we encountered during our on-call. We've got an interesting case done in HUKM. So basically, we start off with this case scenario. So this gentleman, Mr. M, 41 years old, diabetic on single oral hypoglycemic agent, complaining of, came in with acute onset of upper abdominal pain, non-colicky, non-radiating with 5 days duration. It was associated with bilious vomiting, but is still passing flatus and has minimal bowel opening. At that point, he had no jaundice, three-color urine or pale colors too. So on admission, when we assessed in clinically, he was dehydrated, tachycardic. He was basically in sepsis with temperature of 39 degrees. And on examination, there was a tender, vague mass at the left hypochondrium, non-pulsatile and non-ballotable. At that point was white cell count of 23,000 with amylase and LFT were normal. So a CT scan was performed for this gentleman, which shows, you can see from the image itself, it looks like either an intra-abdominal mass or a huge collection measuring about 11 times 9 times 12 with multiple air locules. With contrast still flows through the bowel, small bowel at that point. So after seeing this image, what are your differential diagnoses? All right, either you're looking at is a perforated proximal small bowel tumor, is it a transverse perforated transverse colon tumor, infected hematoma, or pancreatic tail tumor? So we can have a poll now. You can vote for it, and we will see the results. We'll discuss more about it as we go on. So I'm sure everyone would have voted by now. So I'll carry on with my presentation, and we will have our discussion later on. So at that point, our discussion was whether it's an intra-abdominal mass or collection. So you're thinking probably it's a tumor, obstructed tumor with probably impending perforation. Okay, this was our impression at the moment. So basically, this patient was an on-table referral for us. The colleague who has seen this patient before during their on-call, seen the CT scans, and since patient is septic and obstructed, decided to move on to go in. So it was one they have opened up, they called us on table. Okay, so now can we have our polling result? Okay, so interesting part is, of course, most of them have chosen a perforated proximal small bowel tumor, all right? And second was a perforated transverse colon tumor possible, yeah. Looking at the close proximity position, these are the most two common, and of course, pancreatic tumor is still possible. At this point, we were not sure. So this was the intraoperative finding. It was a well-defined mass arising from the small bowel, about 5 cm from the DJ flexure, extending onto the bowel, causing the obstruction. As you can see, the markers, the DJ flexure, it's with the omentum, infiltrating into omentum. Probably that's when we thought it could be a impending perforation, or there might be a micro perforation with omentum wrapping on it. So looking at this picture, next, what are your options of treatment? Are we looking at chop and drop, refer out, resect, end-to-end anastomosis, or resect end-to-end anastomosis with GGA bypass, or duodenal jejunal anastomosis? Again, we can start the voting, and we will have the discussion after this. So we will move on to the next slide. So after seeing this intraoperative, okay, so what we saw exactly was this proximal small bowel tumor. It's not adherent to any nearby structures, important vessels or organs. So we actually performed a segmental resection. As you can see, the anterior surface with the dilated duodenum and jejunum, and on looking at the posterior surface, probably it's already an impending perforation. And the mass is obviously infiltrating the omentum as well. So here there is an obvious bowel obstruction, but this is probably due to the mass arising from the mesentery and enclosing the small bowel wall, infiltrating into small bowel and the omentum. So at this point, before we actually embark on resection, it was actually it's a huge tumor, and its proximal proximity, its proximal small bowel in close proximity to the pancreas vessels, important vessels, especially the superior mesenteric artery and vein. So before resection, the points that one should consider is definitely likelihood going to be a neoplastic obstruction. is mitotic. Okay, patient came in a sepsis is obstruction. At this point, what we should ask ourselves is whether we can achieve a curative resection with clear margin. And because at this point, we're still not sure what is the potential diagnosis. Most common, what everyone would think of, what we thought of also is GIST first. But it could be even sarcoma, which has a very high recurrence rate with poor, high recurrence rate. And then which, if at all we resect, it might recur at the resection margin as well. So there's potential risk of recurrence at the margin and also at the mesentery. So can we have the poll result? Okay. So interestingly, a lot of them has embarked on resection end-to-end anastomosis with gastrojejunostomy. Okay. Okay. What commonly everyone would do is that chop and drop, refer out. Of course, people with a lot of trauma experience, like for us from my previous hospital, HSA, does a lot of this chop and drop trauma concept and refer out. And duodenojejunal anastomosis, some will embark on that as well, but it's on very few, which is also common because a lot of surgeons are not familiar with the anastomosis. Okay, so I think that's why I won't choose for end-to-end anastomosis with gastrojejunostomy. Okay, we will discuss this further. So when it comes to chop and drop, so damage control surgery concept is not really wrong. So in case of major contamination, unhealthy bowel edema, one can opt for this stapling of the duodenum and come back in 24, 48 hours and plan for your reconstruction. But at this point, everybody's concern is, can I staple off duodenum and leave it as a stump? Will the stump blow out? Okay, with this decompression, we have a nasogastric tube decompression, doing a duodenal stump, leaving it free flow, coming back in 24, 48 hours is relatively safe. We have not encountered a duodenal stump blowout at that point. All right. So when you have chop and drop, that means you're going to refer out this patient. You're going to refer to an established referral, a tertiary center with probably an upper GI surgeon, where we can perform this duodenojejunal anastomosis. And we have certainly established a referral pathway where smaller hospital can engage with larger centers in assistance with reconstruction. And most of the upper GI team will help with regards to this kind of a reconstruction. So in our case, what we did, yes, we perform a duodenojejunal anastomosis. As you can see, is a duodenum and jejunum is a side-to-side hand-sewn anastomosis, single layer. And this was done at the D2. And the nasogastric tube was advanced beyond the anastomosis with an intention of one, decompression, second, to start early feeding. But unfortunately, the next day the nasogastric tube dislodged and we just kept it in the stomach for decompression. So when it comes to this kind of complex resection, what should you consider? What are you worried of? Again, we go back to this anatomy. Is the nearby organs, especially pancreas, any injury, trauma to the pancreas, once, if at all you develop pancreatic fistula, it's really a nightmare to manage because this DJ flexure is definitely in close proximity with pancreas and also superior mesenteric vessel. Another point to consider here is this ligament of Treitz. This DJ flexure, once you have resected, to mobilize DJ flexure at that point in emergency setting when the bowel or edematous, it's a bit tricky. So you might not get a good length of duodenum for anastomosis. So probably you might not be able to do a tension-free anastomosis, which is more important to prevent any further leaks. So When it comes to primary end-to-end anastomosis, yes, it's the simplest option after segmental resection. So we have gone through literatures about segmental duodenal resection and how they actually reconstruct. So most of these papers actually have done a small bowel resection with primary end-to-end anastomosis, and most of these are elective settings. And not surprising because most of the case series involve GIST tumor. So this one paper, Nickerson et al., it shows most of their resection. They've done a laparoscopic resection, mostly segmental and primary anastomosis. Their resection involve carcinoid tumor and GIST is the most common. So when you look at primary end-to-end anastomosis, is another journal by Golka et al., limited duodenal resection, surgical approach and outcomes. So when you look at this series, it's a case of 10 cases whereby 8 patients has undergone duodenal jejunal anastomosis after a segmental resection, out of which 5 turned out to be GIST, 2 adeno-CA, and 2 neuroendocrine tumors. Total of 10 cases, and all of them had good post-operative outcome. There were 2 patients that they have done actually a wedge resection and primary repair with gastrojejunostomy. So when you talk about there were an option about primary end-to-end anastomosis and gastrojejunal bypass, which most of you have chosen. All right, so what is the take about this primary end-to-end anastomosis and GJ bypass? There's actually an interesting paper from USM, our colleague in USM, has published. They have had a patient who had similar presentation, acute setting, intestinal obstruction, patient was septic. Their CT scan showed it's probably small bowel obstruction secondary to an adhesion band because there was a transition point at DJ Flexure, TJ junction. So they actually proceeded with laparotomy. But what it turned out to be was a duodenal tumor. So they had to do a segmental duodenal resection. And they preferred to do an anastomosis, primary end-to-end with gastrojejunal bypass as well. So we actually had a discussion with the SUSM team regarding their choice of reconstruction, since they have done a primary end-to-end with GJ bypass. Actually, at that point, their concern was recurrence in the midline. So since this tumor is uncertain, let's say it turns out to be adeno-CA or sarcoma, there's high chance of recurrence at the site of resection involving the mesentery, involving the major vessel, especially superior mesenteric vein and artery, can cause ischemia, can cause obstruction, recurrence, and para-aortic lymph nodes also can cause obstruction. So basically, their reasoning for GJ anastomosis is to assist if the primary anastomosis gets obstructed. So similarly, our rationale to perform this DJ bypass, so we did a D2, duodenojejunal anastomosis, is to avoid the midline, and it is more physiological, assist in biliary drainage. So this kind of anastomosis we don't get by a biliary reflux, bile reflux, and complication out of bile reflux in the long term. And this is actually a common anastomosis we routinely perform in management of SMA syndrome. So when it comes to small bowel tumor, how common they are? So broadly, it is divided into lymphomas, sarcomas, carcinoma, or neuroendocrine cancer. But it's very difficult at the point of surgery when you don't go in to, it's very difficult to differentiate all these tumors at the point of surgery. Okay, a GIST, it can appear like this. It's a good 5-year survival, if not metastatic, and serocapsule if not ruptured. And then what if it comes back as sarcoma? less than 50% 5-year survival due to insensitivity to chemo or radiotherapy. And most of the time, they're already advanced at diagnosis. Adeno-CA, of course, it has a worse prognosis. They already most of the time they are already metastatic with peritoneal deposit and tend to encase the superior mesenteric pedicle. And neuroendocrine tumor, probably they rather have good 5-year survival if they don't have complication with good resection margin. Otherwise, neurocytotoxic, even with metastatic neuroendocrine tumor, have shown good survival. So in our case, what it turned out to be in the end, it was an desmoid fibromatosis. And it was a total 8 lymph nodes were ill and it negative for the lymph node metastasis. So we actually did a scope for him. This is during the follow-up. So when it comes to desmoid tumor, the literature review shows it can occur sporadically or can be associated with familial adenomatous polyposis. So since it can be associated with FAP, we proceeded with a colonoscopy and OGDS and had a look at our anastomosis as well. You can see a clear, nice DJ anastomosis with jejunal lumen, and this is the duodenal lumen. There was no bile reflux. So at that point, this was a patient 1 month post-op, came in on wheelchair, and 2 months post-op, he was very well, fit, he looks fit. So thank you to our pathologist, our breast endocrine team, who has initially attended to the patient. And thank you very much. And we will proceed with Q&A later on. Thank you.
All right, thank you, Dr. Sekkapan, for your interesting sharing of the topics on DJ flexure tumor in emergency setting. I think we are now open for Q&A. There's a Q&A box in the upper end of your webinar page. You can type in your questions now. And while we're waiting for the questions, I think our sponsor for today, LabTech, would like to share with us a short videos on how a ventral hernia repair using a mesh and glue in both laparoscopy and open surgery. And now I pass to LabTech for them to share with us a short video. And now come back to our Q&A questions on Dr. Sekkapan's presentation. I think we have a few questions. The first ones are by our participants regarding to our jejunal anastomosis. Right, I think our participant would like to know, is there any comparison between suture versus stapler anastomosis from your experience, Dr. Sekkapan?
Okay, so in the few cases, especially with the SMA syndrome that we have performed, DJ anastomosis, so most of the time is posterior anastomosis is done with the stapler, and we close the enterotomy. So when it comes to whether there's any difference, from my experience, I would say I'm comfortable doing this hands-on anastomosis single layer, and which has given good outcomes of all these cases, especially our SMA syndrome.
All right, I think the other thing you need to consider the space and area you need to anastomose. I think in the duodenum, our mobilization is very limited, and as a retroperitoneal structures, we want to have a tension-free anastomosis. So it's very important to know that what is the length of anastomosis you want to do, and how much you can achieve with stapler, and how much you can achieve with hand-sewn suture, which is the keywords is a tension-free anastomosis. I think either with suture or stapler, as long as I can achieve these basic principles of hand tension-free, well vascularized anastomosis, we can go away with either stapler or hand sewn. In this particular case, duodenum is actually the blood supply coming from the pancreatic area in the medial side. So your anastomosis, as far as possible, don't go towards the anti-mesenteric, go towards the pancreatic regions. So sometimes with stapler, you may have limited space and you may not able to get tension free. So at the end of the day, you may want to consider suture anastomosis. Anything to add, Mr. Najmi?
Yeah, I agree with you. I mean, duodenum, if possible, if you can use a hand-sewn, probably you have more advantages compared to stapler, unless you're doing laparoscopic resection, something like that, where you think doing the stapling anastomosis faster, and you can achieve good results like what we mentioned before.
All right. Yeah, I think we have a few more questions.
Okay,
Najmi, you want to take the second
question? DJ fracture tumor is in close proximity with major vessels like superior mesenteric artery and superior mesenteric vein. So in the case of that, the tumor is deemed unresectable. So that means on table decision, you do bypass procedure, and if yes, what kind of bypass that you would like to do?
Okay, so in this case, it's already deemed as unresectable tumor involving the major vessels, and patient is obstructed. So we need to relieve the obstruction. Of course, we need to do, I will perform a bypass. Like I've shown in my presentation, I would prefer to do a duodenojejunal bypass instead of gastrojejunectomy. This is for the long-term outcome in terms of bile reflux. Okay, once we have seen many with this gastrojejunal bypass, bile reflux in long term, they do get marginal ulcers, and remnant stomach can turn into CA, carcinomas. So my preference would be duodenojejunal bypass, which is more physiological, definitely assists in a biliary drainage.
Okay. All right. Can you elaborate further what the advantages of let's say GJ compared to duodenojejunal bypass? I mean, because sometimes if you're not familiar with the procedure, sometimes doing DJ is not that straightforward, because if the anastomosis is done in the emergency setting, sometimes the leak rate, etc., becomes a concern. So what do you suggest for let's say general surgeon come across of this case later?
Okay, so like what Mr. Najmi has mentioned, doing a duodenojejunal bypass, of course, technically it's more difficult, and also the space, the structures, which a lot of surgeons will not be familiar with. So in that case, gastrojejunal bypass is always a safer option. It's much easier to do, perform, and definitely a lot of them are familiar with the anatomy and the procedure. So that's when we actually suggest, okay, if we come across this kind of case scenario, if it is elective setting, I think it's quite straightforward, where we're going to refer to the respective subspecialty. But again, what if we encounter this in emergency setting? That's when we actually discuss a few options. If possible, resect and send out for reconstruction by whoever is more familiar with DJ anastomosis. Other than that, of course, if the help is not nearby or there will be delay in treatment, of course, performing a gastrojejunectomy is not at all a wrong option. It's definitely an option.
All right.
Okay, I think it can be quite confusing, DJ Flexure, I think in most of our basic general surgery, anything DJ Flexure and below, is considered as lower GI tract. Again, you have problem with this this area. It may be lower GI tract when you're going to resect, but come to reconstruction, is upper GI tract. So it's going to be no man's land, is it? So you have to know a bit of upper GI, because the general surgeons, you can't be just saying about lower GI and think, oh, this, I don't know what to do at this junction. I think the next question is going to be pertinent to this question, whether this is something related. I think our next participant, you would like to know if this anastomosis end up with complication like delayed hemorrhage after a leakage. What is the usual cause and of all this?
Okay, this anastomosis ending up in complication, especially let's say it's DJ, is again, it comes up to the principle of tension-free anastomosis. Okay, devascularization. So possibly can have a leak, but having a leak at this point definitely will end up will contribute to other issues like especially hemorrhage, proteolytic enzymes causes fibrinolysis and will contribute to the hemorrhage. So
I think this one is anastomosis very high in duodenum, where all the pancreatic juice and bowel will be the first one to get contaminated if there's any leakages, right? Yeah. And I think this area also have a lot of collaterals for portal veins, not only arterial. So most of the time, the bleeding end up will be a portovenous bleeding, which is can be a very high pressure as arterial bleeding and difficult to control. Even with intervention radiologists, they can only block the arterial bleed, but to block a portovenous bleed, it can be quite difficult. So again, like any other ripples or pancreatico-jejunal leak, any leakages in this area potentially cause a massive bleeding or cause a pseudoaneurysm. Right, we move on to the next questions.
Yeah. How about the anastomosis without gastrojejunostomy? I think probably the question referring to just primary anastomosis, you know, with GJ or without GJ. So what do you think about this?
So again, we are going back to what we are dealing with. Of course, whether it's an emergency or elective setting. And most of the time is an elective setting. We already know the histology of the tumor, and we can safely perform resection and primary anastomosis. Again, when you come back to emergency setting, our consideration is this kind of aggressive tumor. And even if you say it's just, but it's involving the small bowel, probably, you know, it's impending perforation, it's still high risk. Sarcoma is high risk. So performing an primary end-to-end anastomosis, probably it will be better if you do a gastrojejunostomy as well to prevent obstruction due to recurrence at that point. So that will be my take on this.
Yeah, I think doing GJ actually probably much safer, and you know, as you mentioned, in general, nobody will, you know, argue why you perform GJ and why you don't perform GJ. But I think, or to be on the safer side, performing GJ probably is a good idea. All right, Shyang Yee, can we go to the next one?
Yeah, I think one of our participants would like to ask, when we are performing this surgery resection, how do we prevent pancreatic fistula while maintaining a curative surgery? I think it's the same thing that when we do a radical gastrectomy, where you have to do lymphodectomy along the suprapancreatic, right? How do we going to present pancreatic fistula?
One is familiarity with the anatomy. One should be very familiar before performing the surgery or the steps, keeping away to the clear plane, not to injure the pancreas. That is the most important point. Taking care of the major vessels around the pancreas, especially the superior mesenteric vessels, and keeping to the principle of resection margin. So at this point, how many lymph nodes that we are going to harvest is always a questionable because it's an emergency setting. Again, we are not sure about the histology. But while if you can keep to a good resection margin with away from the vital structures, definitely we can prevent any further complications.
All right, I think close to the anatomy is very important. Where you find where is the inferior, in this case, the DJ flexure, you must know where is the inferior border of the pancreas. At some point, maybe you need to enter the lesser sac, right? You pull down the transverse mesocolon and find where's the inferior border and go along it, find the D3 and D4, so you can avoid injury to the pancreas and cause a fistula. I think it may be complex, as I said earlier on. DJ fracture may sound like low GI, but when you need to resect, get a margin to do anastomosis, you have to go into the upper GI and area and know the anatomy well. We move on to the next question.
Okay, this one quite interesting. I think most of the audience would like to know about this. How early would it be best to allow intake per oral for proximal small bowel anastomosis?
Okay, so again, when it comes to any anastomosis, or especially like this question arises, it says proximal small bowel anastomosis. When do we allow like oral feed? I would say there is no specific date, or days that we consider. By day 3, we allow, day 4, we allow. Again, we go back to patient factor. This patient came in quite ill. So he has been resuscitated. We have done a definitive surgery. So we need to look into his recovery. Patient has recovered well. Physiology is restored. So we have done an anastomosis, which we are familiar of. And definitely my practice is to put in a nasogastric tube to decompress. So about once I see this nasogastric tube, there's not much output. Patient is not in ileus. Bowel sound is present. Patient able to pass flatus. I would definitely start on enteral feed. But whether it's going to be in 24 hours, 48 hours, it all depends on patient factors.
All right. Well, the next question is quite interesting. I think our participant would like to know any difference between the chop and drop surgery method. That means you remove. If you cannot resect, would there be any role or put a? I believe I think he meant by the tube. A tube duodenostomy or gastrostomy tube for decompression.
Okay, so let's say this is in unresectable. Patient is obstructed. So since we have nasogastric tube, even nowadays we have a long nasojejunal tube. With all this new invention, I would still prefer to put in these tubes for decompression purpose instead of performing a gastrostomy or duodenostomy, which I feel it adds on to the morbidity. It's another extra procedure when patient is not well. So we can easily decompress with our tubes, nasojejunal or nasogastric tube.
Mr. Najmi, you got any opinion on this?
It depends on the situation. I think you must decide. Depends on the case that you come across. I think Sekkapan already give his opinion about that.
Yeah, I think in this case is you worry about obstruction. If you don't know, you're not familiar anatomy, the GJ bypass is still acceptable, right? Then until you send it to the other center to have a definite surgery. So I think if you put a tube, duodenostomy, a tube is more morbid if it still can leak around the tubes and cause more problems. You rather to have a palliative setting there you put to GJ to decompress, to bypass the obstruction first until the definite surgery can be done. Right. Next, we move on to the next questions.
How many centimeter distance from the tumor? I mean, the margins for resection, proximal and distal.
So like this particular case, in terms of distance, we kept it to at least more than 2 cm. So to say whether this clear margin, you need at least a microscopic margin more than 2 centimeters. Some literature even keeps it to about 5 cm proximal and distal margin. But to get to up to that extent, 5 cm, if in my particular case, is technically it's difficult because of the location. So we just, for this particular patient, it was about 2 centimeter margin, proximal.
Actually, yeah, like what you said, because our concern now at the duodenum, sometimes if you are looking for 5 centimeter margin for duodenum, of course, it's not that easy. But duodenum, I think should be okay on the jejunal part. But in terms, let's say, when you're talking about GIS, so I don't think you have to look for more than 2 centimeter margins for GIS. All right, we move on.
Okay, right. I think this is something to do with your anastomosis. Maybe Sekkapan would like to answer some of participants that in this case obstruction, there's definitely going to be proximal dilatation and distal end of the bowel going to collapse. There'll be size discrepancy. How are we going to deal with these anastomosis problems?
So when there's size discrepancy, okay, more than 1:2, we can't perform end-to-end anastomosis. At that point, it's not feasible. So my preference definitely is going to be a side-to-side anastomosis, which I feel it gives good outcome. Technically, it's easier to perform. Another option will be end-to-side anastomosis instead of primary end-to-end, which actually brings higher chances of more risk of leak.
Okay, you got a point there, Sekkapan. I think it's very important that whether it's small bowel or any bowel surgery, colon or what, it's not always anastomosis end to end. You must see the discrepancy diameter of the bowel. The safest one is side to side, right? Because you can size your anastomosis side to side regardless of any discrepancy, or end to side, right? So this is the basic principles you need to know, and we can always modify according to our level of difficulties during the surgery. Our next questions, Najmi.
Okay, if a center without upper GI surgeon encounters such case, so chop and drop strategy was employed. So, I mean, now chop and drop become famous procedure, I guess. And case referred to you for definitive reconstruction. Will you perform only DJ anastomosis or primary anastomosis and DJ? So, is it safe to leave the stump alone? You get the question?
Okay. So again, right. So if you have chosen cut and drop, then send to us. So again, we are talking about reconstruction at this point. So like I mentioned earlier, my preference definitely is going to be at D2 anastomosis, DJ anastomosis, which again, it goes back to whether it's more physiological and in long-term outcome that gives a better outcome. So whether the stump is going to blow out, at this point, if you have done the surgery, you are assisting the biliary drainage at D2 into jejunum. So I feel there is no reason for the stump to blow out. And most of us right now, we use staplers and we reinforce the stump as well. That is in emergency setting. And it comes to us, we have done the anastomosis at D2, assisting in biliary drainage. So far, I think there's no issues about duodenal blowout.
All right. Even if duodenal stump leak as well, I think as upper GI centers, most of the time it can be managed. Right.
Okay, I think our next question can be something quite common we face when you do a gastrojejunostomy. Person would like to know what is the experience with gastrojejunostomy stricture.
Okay.
Or I would say maybe obstruction. Maybe the more accurate word is obstruction. What's the common cause? And how are you going to deal with it?
Okay, again, it comes back to technical issues. Okay, you have just performed gastrojejunostomy and it gets obstructed. You have to look at see whether it's because of the orientation of the bowel, the anastomosis, whether it was done, it was in a very, I would say, small anastomosis, whether you have done the sutures, causing it. So at this point, let's say if patient is obstructed and it is confirmed, then we have no choice. I would actually open up to have a look. And let's say if there is a bowel twist or is purely a technical issues, I would resect and redo the anastomosis.
So you're going to resect and do anastomosis, right? Well, I think to do a redo surgery during an immediate period of index surgery may be quite difficult. I think importantly, why the stricture occur, you know, the stomach is very vascularized structure due to ischemia is quite unusual. Mainly it's technical factors like anastomosis leak, right? Your GJ, you don't do it properly, or you use a stapler, you do not close it. Your enterotomy site, you didn't close it properly, there's a leakages. Then all these things cause fibrosis and stricture and cause obstruction. So it's very important that technically do it well, waterproof, you know, you have very tight anastomosis that no leakages occur. Another thing is that you can do a loop GJ, your efferent or efferent loop may tend to kink, you know? You drop down at the edge of the anastomosis and cause obstruction. So sometimes we give additional stitch and the seromuscular stitch between the GJ about 1 centimeter away from each end of the afferent or efferent loop of GJ. You prevent this kink. All these kinks sometimes can cause obstruction. Of course, there's other way, sometimes immediate way we can prevent immediately. You can do some of us may do endoscopically. We find where is the obstruction site. We may want to do an INET, we call it endoscopic nasojejunostomy tube. You pass a wire through where the thing is a stricture, put a nasogastric tube across it to decompress it, let the edema subside, and sometimes you're quite lucky, you may get away from redo surgery. So these are a few things that we can consider when you have problems with GJ stricture. And maybe for the interest of time, we take the last questions.
Yeah. What would be your advice if the HPE reported margins were involved? What further resection would you perform?
Okay, so let's say margins are involved, and going in for another resection technically is very difficult. So at that point, again, it comes back to what is the HPE is about. Where even if it is a GIST or if it's a sarcoma, it's already high grade because this is also an impending or probably is a perforated tumor. So at this point, I will subject this patient for based on the HPE, whether it's chemo or radiosensitive for adjuvant therapy. But definitely going in resect again to get a clear margin, probably not.
Yeah. Okay, I think that's fair an answer.
So you think for Desmoid, the margin is not clear, it's all right to leave it until they recur? Or?
Because there are adjuvant therapies for the desmoid. Of course, the recurrence rate is as high as 20 to 30%, even in with clear surgical margin. So at this point, we will embark more on the adjuvant therapy instead of any more surgical resection.
Okay. Any last words, Mr. Najmi, for our participant tonight?
Quite an interesting case, although I think it's a bit rare. So for gender surgeons and people are working without proper setup, everything. Don't worry too much because it's just an example, a rarity in our surgical practice. Sekkapan already highlighted what are the options that you can do. Just a few words from me before you decide, to operate on a certain patients based on presentation and the imaging that you have. Probably, we have so many things now. Probably you can ask around and discuss, should I proceed with the surgery in my center or instead of doing like chop and drop and refer later. So probably referring the patient before you touch is better. So otherwise it's a nice presentation.
All right, okay, Sekkapan, well done. I think you They'll highlight to us that this DJ fracture is not a lower GI anatomy problems. It can be end up with upper GI problems because approximately you need to deal with it and how to anastomosis to it. There are a few more questions that we couldn't answer tonight, but I think I assure you that our presenter, Dr. Sekkapan, will try to answer you and reply through your emails. And hopefully you can benefit from tonight's webinar. And before we end, I think I would like to thank my co-moderator, Dr. Najmi, our excellent presenter, Dr. Sekkapan, and of course, our tonight's sponsor, LabTech Medical, for sharing with us this very useful webinar tonight, and also their techniques on glue and mesh. And don't forget, next week we have our 6th series, and Dr. Ng Chongbeng will be presenting to us something that is dreadful but important topics for our trainees here: evolving option in the management of esophageal perforation. It will be moderated by our upper GI surgeon for the Southern State of Johor, Dr. Hans, and also Dr. Lim Hui Ching. And before I forget, all right, tomorrow when you receive your email on the survey, please reply the survey. And also, if you have any question to our sponsors tonight regarding their glue and the mesh, you can ask in the survey form, and our sponsor will get back to you. I think with this, I thank everyone for your time and participation tonight. Until we see again next week, 6th series of UpperGI virtual ground. Right. Good night, everyone.
Okay, bye.
Thank you.
Right.